Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to be talking about antiplatelets and anticoagulants. So our table of contents today includes what is blood. So let's just talk about blood overall. Then let's talk about hemostasis. Hemostasis is just the balance of the circulatory system. So we'll talk about that. Then we'll get deeper, slightly deeper, into thrombus and embolus, then platelets responses to vascular trauma. That's our goal today. How does our blood vessel treat injuries on its own? That leads us to the coagulation cascade and clot formation. And this is the most important topic for today, the coagulation cascade. Then we'll move into the theory of blood clotting factors. Very, very, very important, especially in the exam perspective. And then fibrinolysis, which is clot digestion. As well as now the pharmacology will be introduced with anticoagulants and antiplatelets, as well as procoagulants, which are supposed to fight breakdown of clot. So these are basically the antis of one another. Well, moving on to hemostasis in dentistry, how a dental environment deals with local blood loss, and then of course summary. I've started now adding this alert window here. It just lets us know that we need to keep our eyes out for several of these terminologies. In this lecture, we want to keep our eye out for Warfarin, Heparin, Aspirin, and there's no G here, it's an aspirin, apologies for that. Clopidogrel, dabigatran, idarucizumab, apixaban, and the other mab, as well as vitamin K, streptokinase, aminocaproic acid, and tranexamic acids. So we'll take a look at what they are. I know there are a lot of terminologies in there, but let's take a little dive into the blood. So what is blood? Essentially, there is one stem cell. Okay, so pluripotent stem cell is basically a cell that resides in our bodies in certain areas such as the bone marrow, for example, and it turns into either the lymphoid stem or the myeloid stem. And these are still both stem cells. So if we look at the myeloid, with of course the interleukins and all the other enzymes, ultimately we have something known as erythroblast. Erythroblasts turn into erythropoietin, which is a process of maturing into erythrocytes. And guess what erythrocytes are? They're actually just RBCs. Now, because this is a part of blood, the same mother cell, the pluripotent cell, can turn into white blood cells, which are all neutrophils, basophils, eosinophils, and monocytes. Monocytes, macrophages is the defense mechanism. And of course, we will talk about all of this in our section in general pathology in the future. And then, of course, we have the formation from myeloid stem into megakaryoplasts, into platelets. And this is where we are for today's lecture. The lymphoid is actually more so a defense mechanism. So it's a line of defense with all the B cells and plasma cells. Then it moves into T cells in categories. This is all our army. They actually physically fight the other structure. Now you notice how it says bone marrow, blood, and tissues? This is very important because a pluripotent cell, which is normally a stem cell, can turn into anything. In the bone marrow, it takes these categories. And then moving into blood, when the bone marrow is exited, blood is entered, they take very specific numbers and letters. And that's when they enter the tissues and assume their roles. So this chart is just to summarize how we get to a specific cell from a pluripotent cell. That's all it needs to be for hemostasis. Now, in all of these are descriptive terminologies of red blood cell and their changes. So, for example, we've heard this a lot, right? Sickle cell anemia. What is sickling? Sickling is basically RBC that turns into a sickle shape, where it becomes a sickle cell disease, and then it's passed on genetically. Then what about spherocytes? Spherocytes are basically round erythrocytes, which are not biconcave. Now, why is this important? Biconcave cells, so essentially it looks like this, This is what an RBC looks like. It's an actual 3D model, of course, but it's what it looks like, biconcave. However, a spherocyte is a round erythrocyte, so more so like a right round ball. It is caused by hereditary spherocytosis by immune or microangiopathic hemolysis, so breakdown. So essentially, these terminologies are all associated with diseases, majority of them being hemolytic, meaning breakdown of the RBCs in a different way, and as well as they are traits, which means they are genetic, hereditary, absolutely. Okay, so that's all the introduction. We're just trying to warm you up into blood. This is going to be a long lecture, but I know you guys love it, and it's very well crafted to keep you engaged, and I'll make sure to crack a couple jokes here and there. So here we go, hemostasis. Essentially, it's a regulation of blood fluidity, then repairing vascular injuries, as well as limiting blood loss by clotting. So we want to limit blood loss, which is by clotting, known as thrombosis. A thrombus is a clot. And then, of course, protecting against the clot breakage as well. When a clot breaks, it just doesn't directly dissolve in the blood vessel. When a clot breaks, it runs right into the blood vessel. That running clot or floating clot that has been dislodged from the original site is known as an emboli. So thrombus and embolus. All right. The disturbance of hemostasis is displayed by either extreme or excessive bleeding or by forming a clot, thrombosis, that doesn't need to be there. So what are some common causes? Well, we have genetic bleeding disorders. We've talked about that. Acquired clotting defects. Now, acquired means either viral, bacterial, so on and forth. As well as secondary to infection or cancer, basically a systemic disease, shutting down our RBC, our circulatory system. Fun fact, coagulation factors that initiate clotting, they have two systems, extrinsic, intrinsic. So I know we'll get into this in the next few slides, but I'll explain it to you. Every vessel right here has, so this is the inside of the vessel, right? And then they have connective tissue here. Connective tissue, then they have their epithelial layers, and then they have their mucosal layer. Okay, fair enough? Now, whenever there is an injury right here, that is intrinsic. Inside the blood vessel, everything's inside. What about extrinsic? It's when there's a breach into the connective tissue because of the bleeding or even the clot dislodging. That's when the connective tissue begins to interfere in this process, and that's extrinsic. But we'll, of course, get into deeper ends. Platelets, they aid in forming a clot. Platelets are actually sticky molecules that get activated and they start growing hair. And that hair sticks to one another using certain glue-like molecules, which we will talk about. And that is now a clot. This used to be sparse platelets. Next is anticoagulants and antiplatelets. They tend to interrupt this process. Now they can stop at the hands forming. They can stop at the two hands sticking to one another, or they can just stop platelets once and for all. So we'll take a look at all of that once we get into those slides. All right, moving slightly deeper. A thrombus is a clot that adheres to the vessel wall. Okay, an embolus is the clot that floats. Fair enough? Perfect. Well, here's the fun fact. An arterial thrombus is usually due to platelets and atherosclerosis. It needs antiplatelets as treatments. Now, this sentence, let's break it down. Arterial, platelets, atherosclerosis. A coronary artery, arterial, remember? Artery that has a collection of platelets or atherosclerosis can form a clot, a thrombus. This is known as coronary artery disease, also known as IHD, ischemic heart disease. Therefore, you need antiplatelets if platelets are the cause. Therefore, aspirin is a treatment for coronary artery disease. Aspirin is an antiplatelet mechanism. Remember, whenever platelets cause this type of a clot in an artery, we give antiplatelets. Keep that in mind. Artery, clot, antiplatelet. Venous thrombosis is usually due to inappropriate coagulation. So, venous, meaning veins, is usually due to inappropriate coagulation. It needs anticoagulant help. Therefore, warfarin is the treatment of deep vein thrombosis. Remember the disease DVT, deep vein thrombosis? That's explained right here. In this case, we have a healthy vein, then we have blood pooling, and then we have blood clot forming, and ultimately a thrombus adheres to the vessel wall, and some of the embolus kind of floats away. In this case, it is the blood clotting, not the platelets. Therefore, it is inappropriate coagulation, and we need anticoagulants. Therefore, we need warfarin. Okay, so that's the big difference. Now, of course, they can interchange, but this is the major feature. Okay, slightly deeper again. Hemostasis disorders are either thrombotic disorders or bleeding disorders. Thrombotic disorders are unwanted clots. So they can be called as, and here we go, one more term, thromboembolic disorders, where a clot can form and clot can dislodge and run around as well. These are myocardial infarction, deep vein thrombosis, pulmonary embolism, and acute ischemic stroke. Now, remember this terminology, stroke. Stroke can be due to either a clot or it can be due to a release of a clot. What is stroke? Stroke is either lack of blood supply or a very fast blood supply to an organ that hurts it. Fair enough? Thromboembolic. This can be treated by anticoagulants, antiplatelets, fibrinolytics. So in essence, this is antiplatelets. This is anticoagulant. And that's important to know because of vein and then myocardial being the coronary artery disease. Okay, so I just wanted you guys to keep remembering that. It's very easy to make notes on those points. Okay, moving on. Bleeding disorders, failure of hemostasis, basically inappropriate coagulation. And they have their several diseases as well, such as hemophilia A, B. Now we're introducing factors 8 and 9. So A8, B9. These are hemophilic diseases. These are deficiencies of coagulant factors. When they're deficient, there's failure of hemostasis leading to bleeding. Simple? And then there's another disease called von Willebrand disease and vitamin K deficiency. We'll keep that on the hold because vitamin K causes clots. Whenever there's a deficiency, it increases clots. Simple? So that's vitamin K. And therefore, they're treated by factors replacements and vitamin K administration. Nice and simple. Okay, platelet response to vascular injury. Now, this is the longer portion of the lecture today, so let's brace ourselves. Physical trauma to vascular system, basically a cut that bleeds, begins a series, hence a cascade, of events. They involve platelets, endothelial cells, and coagulation factors. We already talked about factor 8 and 9, remember? Endothelial cells we talked about in slide 1 with the pluripotent cells moving into erythrocytes and so on. These are endothelial cells, which means cells that reside in the vessels here. Okay, and then of course platelets we know for today's lecture. The outcome basically is cessation of blood or a formation of clot. That's basically what the platelets end up doing during a vascular injury. So let's take a look at the flow of sequence. The physical trauma clot has intended thrombus. So whenever a body generates thrombus, it's intended. It's when vasospasms happen, then they organize into platelet and fibrin plugs. Very, very simple. The body wants to resolve the situation, creates a plug made with platelets and fibrins. Once they're made, bleeding stops. But whenever pathology is involved, a trauma clot process is unintended. Therefore, vasospasm does happen, but the clot is very disorganized. And how? We will learn. So for example, in hemostasis in this diagram, there's vessel constriction, and that is vasospasm, spasms of the vessels. And basically there's an injury here and RBC is almost leaving the blood vessel. Therefore, the blood vessel will constrict itself. Why will it constrict? Because that constriction invites platelets and other fibrin molecules into the injury area, and it causes what is known as a plug. And that plug is made up of fibrins. And we'll take a look at the fibrins, which is fibrin clot conversion. Okay, so here's the big story, okay? It's a 9-step story. First one, there's resting platelets. Basically, they're resting on the subepithelial layer, some in the blood vessels, just roaming like the police, okay? So they have a siren sensor on them, and they run around. They're in the healthy, intact endothelium, collagen fiber is covering it, everything's up to date. Inactive GP2B and 3A receptors. Now, every platelet cell, so when we zoom into this one blue, it has some receptors at the very edge on the membrane. Now, GP is glycoproteins. Glycoproteins, 2B, 3A. Okay, so essentially, if you think about it, this police car has sensors on it. And these glycoproteins are those sensors. What do? They tend to interact with signals that come to them and tell them that, uh-oh, there is an injury. Please proceed to the following protocol. So what is that protocol? Let's take a look at inside the cell first. Do you see there's calcium? Calcium involvement, CAMP involvement, ATP involvement, and of course prostacyclin and nitric oxide. So many different chemical reactions, right? Well, let's take a look what happens. In a healthy intact endothelium, they release prostacyclins into plasma. Basically, an injury signals, they release a walkie-talkie message, just like the cops do. So prostacyclin is released. They bind to the platelet membrane receptors, so they would then go ahead and bind, right? New forces back up. The police backup is here, and it causes synthesis of a CAMP. Now, this important molecule here, CAMP, acts as an enzyme, right? It's basically artillery. All of these cops with the prostacyclin attaching to the sensors with the police, they add up and they come up with a defense mechanism called the CAMP. And the CAMP is your guns and bullets and bombs. They stabilize the inactive GP receptors and inhibit the release of granules containing platelet aggregation agents or calcium. So what does that mean? Basically, whenever the CAMPs activate the glycoproteins, they end up inhibiting the release of granules that contain platelet aggregation agents or calcium. Very, very important. As soon as the police start firing, they tend to set off all the thieves. All the thieves and the criminals, they stop working. They stop working right away. So, platelet aggregation agents or calcium right over here, they stop working. And all of a sudden, platelet says, uh-oh, there's something that's not working there. Let's go ahead. So platelet begins to adhere. So activated platelets then cover and adhere to the exposed subendothelial surface of damaged vessel. And all of a sudden, all the blue platelets come and sit in that crater of the injury, right? Afterwards, platelet activation takes place. So once they sit down, they become activated. The thromboxane A2, ADP, serotonin, PAF, oh my God, there's so many molecules. We'll take a look at them, don't worry. Basically, these are chemical mediators that these adhered platelets, they release into the blood. Whenever these chemical mediators are released, the platelets are now activated. Basically, all of these thieves and all the cops engaging with one another started setting off a gunfire. And that gunfire made all the situation get activated, all arms up, activated. And of course, what happens when guns are raised? There's aggregation. So all the platelets are recruited into the platelet plug. So basically, thieves get more thieves, the criminals get more criminals to fight, and the police get more police to fight. And they end up aggregating by preventing bleeding. They form a clot. Now let's take a look at what each molecule does inside this platelet in this magnitude over here. So we talked about things like thromboxane A2, thrombin, ADP. I know we haven't dived deeper, but we'll get there. Essentially what happens is they enter the platelet cell along with other chemical mediators. When they enter, they become a granule inhibiting factor, and they move out after their work is done. Once they do, they invite more. So essentially, this process with arachidonic acid, prostaglandin, H, thromboxane A2, leading to the thrombin, so on and forth, basically all it does is conversion of an adhered platelet to an activated platelet to an aggregated platelet. That's what happens. So a thrombin, thromboxane A2, ADP, and other mediators released from activated platelets, they bound. They stick themselves to the collagen. So all the police come and they stick themselves to the wall of the crime scene. And they stick themselves by various certain granules, such as activation of GP2 receptors and fibrinogen. Now we have a new terminology. So two police officers, they bind themselves together using the receptors we talked about and fibrinogen as the sticky molecule. Fibrinogen is the fibrin clot forming molecule. So when they attach them with one another, they cause a release of calcium levels. There's an increase in the calcium levels in the cells. Okay, so what happens if the calcium goes up? That's when we realize that fibrin clot begins to form in a cyclical manner, right? Calcium increases, calcium will increase the activity of the platelets, platelets will increase, platelets will join by the fibrinogen, then calcium will be released, and back and forth and back and forth. So we realize that after a fibrin, which is converted from fibrinogen, of course, is inhibited by a process of fibrinolysis, then we realize that the clot can also break. Okay, let me explain that. In here, we're learning that there's a formation of a platelet fibrin plug, right? Fibrin goes there, it prevents any breakdown just as of yet. There's activation of coagulation factors in the plasma as well. Those coagulation factors such as prothrombin and thrombin, they activate more fibrin, then they move into the platelet-rich area, creating a platelet fibrin plug. Okay, great. But soon enough, this fibrin will be inhibited by other molecule known as plasmin. I know I'm throwing so many terminologies, but this is just a diagram. Don't worry, I will explain everything. Ultimately, a fibrin clot ends up growing and growing and growing and growing, but it needs to stop somewhere, right? That's where the body releases fibrin digesting molecule known as plasmin. And plasmin is made from plasminogen. Did you guys notice a pattern here? Fibrinogen makes fibrin. Plasminogen makes plasmin. And ultimately, plasmin dissolves a little bit of this clot to maintain the clot, to moderate the clot. And this process is known as fibrinolysis. This is the long story. I know it was back and forth, but now let's take a look at it with more analytics. So you can write some notes down. Stage 1 is resting platelets. This is when there is no injury, nothing yet, okay? Let's see what happens. Well, normally platelets, they patrol the vessels looking for signals of the vessel trauma. Vessel integrity police, you can call it, right? VIP. Told you I'll crack a couple of jokes in the middle. Okay, chemical mediators. Prostacyclin, PGI2, is an inversely proportional relationship with platelet aggregation. See the table under for details. Okay, basically what inversely proportional means is a high prostacyclin level means low platelet aggregation. Fair enough. Whenever there is no injury, of course, there will be a low platelet aggregation. We don't need a clot without an injury. Therefore, in a normal vessel, prostacyclin will always be high, just like here. So far, so good. As soon as the prostacyclins drop in number, there is a high platelet aggregation. This happens in injury. Damaged endothelial cells will drop into prostacyclin levels. Fair enough? Okay, so normally, when there's, again, no injury, higher prostacyclin, they bind to platelet receptors which are responsible for cyclic AMP, which is cyclic adenosine monophosphate. Cyclic AMP then decreases calcium levels inside the cells. Because there's less calcium, there's less platelet activation and less platelet aggregation. And because of that, more prostacyclin comes up, leading to the cycle again. But imagine if this is dropped. If there is an injury and this dropped, then what would happen? Well, everything would reverse. It would end up ultimately increasing platelet aggregation and decreasing prostacyclin. That's what would happen. Okay. Now, in resting platelets, we want to talk about certain chemical mediators such as thrombin, thromboxane, collagen's function. So like cyclic AMP and prostaglandin, or prostacyclin, I must say. This is prostacyclin. Platelet membranes also have receptors for other things, such as thrombin and thromboxanes, specifically thromboxane A2. In an intact vessel, of course, there's low levels of thrombin and thromboxane because you don't need a clot. Therefore, thrombin and thromboxane are responsible for clots. In a normal vessel, there's less. In a damaged vessels, there's high number of thrombin and thromboxane A2. These high levels of mediators, they increase platelet aggregation. Intact vessels, collagen is covered by endothelium, safe and secure. But in a damaged vessel, collagen net is exposed. Because of that exposed net, platelets gets invited and they just stick to the collagen, making a activated plug. Fair enough? So it is now safe to say that to increase platelet activity, you need the following. You need decreased prostacyclin, you need decreased thrombin, you need decreased thromboxane A2, and you need a broken collagen net. Fair enough? Okay. This is resting platelet. Remember when we said they're just resting, no arms, nothing to stick to. But as soon as they're activated, they have phalanges. Arms, they come out, they stick to one another using this glycoprotein receptor, and they just kind of hold hands, basically. Okay, moving on. Now that we've established that there is an injury, as soon as there's an injury, we have a drop in all of those levels that we talked about, right? The thromboxane A2 and all. As soon as that happens, platelet adhesion take place, which is when a vessel is damaged, the platelets are drawn to sticky collagen that is exposed during the injury. Step 1 clear. Platelets are now covering the subepithelium in more like a plug. This stunt by platelets triggers a series of chemical events leading to more platelet activation after, and that's platelet activation. The stimulation by collagen and the stuck platelets, it activates them. Now the platelets change shape and size and they release granule signals. Now we're talking about that signal, and the signals are known as ADP, adenosine diphosphate, thromboxane A2, thrombin, and if you remember from the diagram, there's serotonin and PAF, which is platelet activation factors. These are all signals that are now released. These granules ultimately reduce the cyclic AMP. Therefore, of course, they will increase the calcium in the cells. And as soon as calcium increases in the cells, they invite more platelets to join the adhesion and, of course, lead to aggregation. Fair enough? Following so far, you guys? Perfect. Platelet aggregation. Whenever there's high calcium inside the cells, there's an increased release of mediators that mentioned above. ADP and serotonin, their job is to recruit and activate more platelets. Thromboxane A2 synthesis also increases. Now, thromboxane A2, very, very deep and very important molecule, and we will talk about this very particular piece of molecule, the mediator, in detail in the future slides. And of course, how can we forget the glycoproteins? The GP2B and 3A receptors are now activated, and all the receptors, this is supposed to be GP, apologies guys, GPs invite fibrinogens. Do you remember those yellow dots that we saw in that diagram? I can show you what that looks like, you guys. In the diagram we saw that the glycoproteins, this glycoprotein had the yellow dots right here, fibrinogens. They end up creating a bridge in between the two molecules. Perfect? Let's get back. The glycoprotein receptors are activated and they invite fibrinogen, which bridge the gap between two platelets, causing aggregation of platelets. Moving on. Formation of a clot. Along with platelet-based mediator, there are other tissue factors. Now we're moving into coagulation. Okay, so we did platelets. Now we're moving into coagulation. One of those factors is known as thrombin. And guess what another name for thrombin is? It's factor 2A. It catalyzes the conversion of fibrinogen to fibrin. Why do we need that? Well, remember, the clot was known as the fibrin clot, the fibrin plug, not fibrinogen. So what that really tells us is that when fibrinogen is recruited in this slide, it's inactivated. But you need something to jumpstart this fibrinogen, and that is thrombin. And thrombin is actually a coagulant factor, factor 2A. And of course, fibrin is now activated, causing clot formation. These factors induce fibrin strands and priorly recruited, activated, and aggregated platelets to form something we like to call as platelet fibrin plug. How beautiful is that, guys? This plug is what brings back hemostatic status of the injured vessel. But unfortunately, if this clot is not stopped, it just keeps growing and growing, growing. Therefore, the bodies come up with beautiful fibrinolysis. What is fibrinolysis? It's a clot breaker and a regulator process. Normally, this above-mentioned process is accelerated and does not stop unless fibrinolysis is introduced. The limitation of growth of thrombus or clot is necessary. Otherwise, there will be something known as a vessel occlusion, and that's worse, you guys. Therefore, again, plasminogen, the very last thing we saw in that slide with the diagram, which is inactivated, it turns into plasmin as an activated molecule by its own tissue factor, which is over here. Tissue plasminogen activator. This right here will turn plasminogen, the inactivated molecule, to plasmin, which is the activated molecule. All right. And then, of course, it begins to dissolve the fibrin network once hemostasis has been achieved to maintain basically a integral size of the clot. However, fibrinolysis can lead to a breach on platelet fibrin plug and cause unintended bleeding, and that's what exactly bleeding disorders are. Inability to clot or over breakdown of a clot. Therefore, it also needs to be controlled, such as during bleeding disorder treatments. Wow, guys, that was a long story. Okay, let's take a look here. This is a wall defect in the blood vessel wall, endothelial cells. As soon as that is detected, this is the collagen fibers. Collagen fibers will end up seeking lots of platelets, and this is the platelet cell. Platelet cells have GP receptors on top. GP receptors do two things. They bridge the gap and they invite fibrinogen. Fair enough, this is fibrinogen. And these platelets will then release certain molecules. These are signals, these are mediators, which is adenosine diphosphate, thromboxane A2, serotonin, this is short for serotonin. When they get released into the blood vessel from platelets, more platelets are invited. More platelets are invited, there's degranulation. Prostacyclin drops in its numbers to activate this further mechanism. Fair enough? And then, of course, we have an intrinsic and an extrinsic manner that affects a clotting factor. Clotting factor then turns prothrombin into thrombin. Thrombin, which is factor 2A, turns fibrinogen into fibrin. And of course, it creates a clot at this region here. That is the full story, you guys. Okay, that was platelets. Now let's talk about coagulation cascade. Clotting factors. This could be an exam question, so let's listen up, you guys. The formation of thrombin, which is factor 2A, which leads to fibrin network. Then the plug is initiated by coagulation cascade, consisting of two pathways. So this section right here, right? So I'll change colors just so that we're able to see better. This section right here is part of coagulation cascade. This section right here is about platelets. So it's two in one, two mechanisms, okay? So there are two pathways, intrinsic and extrinsic. In intrinsic, we have factor number 12 activated by exposure to collagen of damaged vessels. Okay, so basically in the blood vessel, if there is a clot that needs to be formed at this breach, it will only form at collagen fibers. We learned about that. But because of this collagen being exposed to the blood, factor number 12 gets activated. And that is intrinsic cascade of coagulation. However, extrinsic is when factor 7 is in play, and that is thromboplastin. That is when there is exposure to blood. So basically, all the endothelial tissue here, muscle fibers, blood seeps out and they get extrinsically affected, and then they send defense mechanism inside the blood vessel. This is by factor 7, and that is thromboplastin. Okay, let's take a look at this chart here. That way we can understand what numbers and factors go after one another. Okay, here we go. These factors are inactivated by heparin antithrombin complex. Remember this because it will help us in anticoagulation section. So heparin antithrombin. You guys see how it says antithrombin? Thromboplastin, antithrombin. It is normally inactivated by this complex. However, upon injury, that can't be the case. It has to be reversed. The synthesis of these factors is inhibited by coumarins, which is a warfarin. So warfarin. Okay, so warfarin is an anticoagulant. Now, we talked about two words right here, heparin and warfarin. Remember this, heparin, warfarin. These both drugs are anticoagulants. They inhibit this process. Warfarin inhibits the synthesis of all of these, and heparin inhibits activation. Fair enough? Okay, don't forget that. We will come back to it in the later slides. So intrinsic pathway, remember we said that factor number 12 gets activated to factor number 12A. That then activates factor number 11 to 11A. 11A activates number 9 to 9A. 9 activates number 10 to 10A. 10A turns prothrombin into thrombin. And remember what thrombin did? Thrombin converted fibrinogen to fibrin. And voila, we have a clot. Perfect. That is during an injury. As soon as this clot process has begun, this activation process has begun, and if you took heparin, then none of this will take place. Okay? And that's why it is anticoagulant. Now, extrinsic pathway. Extrinsic pathway, remember factor number 7 gets activated to 7A, which is thromboplastin, which then activates number 10 again to 10A. And 10A converts prothrombin into thrombin, inactivated into activated, which then converts fibrinogen to fibrin, and again, we have a clot. But as soon as you take coumarins, which is warfarin, none of these are actually even produced. Number 12 is not produced, number 7 is not produced, therefore a clot is not produced, and that's the magic of warfarin. Anticoagulant. Okay. Coagulation cascade, basically a formation of fibrin. Both intrinsic and extrinsic systems are involved. Sequential transformation of plasma factors, which is from proenzyme to enzyme. So, for example, a fibrinogen to fibrin. That's basically what they're trying to say. Note, in the activated factor labeled A. All right, so we notice that a lot. Let me get rid of everything on the slide so it's easy to see. Right here, a normal number turns into number with A. Number 10 turns into A. So what is that A? Activated factor is labeled as A. Therefore, a sequential transformation of these proenzymes to enzymes is associated with the letter A. For example, factor 7 into 7A. All factors cascades, they lead to the formation of 10A. Ultimately, 10A is formed. That's the goal. 10A converts prothrombin into thrombin. That's the main goal. And of course, thrombin is responsible for the formation of fibrin, and this is coagulation, you guys. Antithrombin factor, which is factor number 3, is responsible for the inhibition of coagulation. So, if factor number 3 decides to show up here from nowhere, all of this can stop. So, inhibition of coagulation. But heparin kills number 3. Remember that? Heparin antithrombin complex. That complex inactivates these factors. Perfect. Moving on. Inhibition of coagulation. Antithrombin 3 will limit the growth of the fibrin network, which holds the intention to merge with the platelets to form a plug. Fibrin has to meet the platelets. Antithrombin stops it. Along with antithrombin 3, there are other inhibitors out there, known as protein C, protein S. They play a role in anticoagulation as well. Anticoagulant drugs such as heparin, it activates these antithrombin 3, protein C, and protein S's. As soon as that happens, there is an inhibition of coagulation. Inhibition of coagulation. And now coagulation is inhibited. So stimulation, inhibition. Coagulation cascade and clotting factors. So I know we went through this, but here's with names in a proper summary. Factor number 1 is known as fibrinogen. We know where to find that now. Factor number 2 is prothrombin. The target for action, heparin and warfarin. Factor number 3, we talked about tissue thromboplastin, which is antithrombin. And factor number 4, calcium. Calcium is an actual coagulation factor, you guys. Fun fact. Other factors, which is factor number 8, which then is antihemophilic factor. Remember, when there's a deficiency of factor number 8, we had hemophilia A. Okay, antihemophilic. Factor number 9 is also known as Christmas factor, plasma thromboplastin component. Christmas factor, warfarin. Remember, when factor 9 is low, we have a disease known as hemophilia B. Factor number 10, very, very important. It creates a synonym known as Stewart-Prower factor. That's what it's known as. And heparin, rivaroxaban, apixaban, and warfarin, these affect factor number 10. Most important factor, right? The last factor down here. As soon as this is reached, coagulation will occur. So all of these drugs will target that area and prevent the clot formation. And then factor number 11, which is plasma thromboplastin antecedent. Factor number 12 is Hageman factor. Factor number 11 and 12 are generally up ahead. Remember, we had this diagram here where factor number 12 and 11 are intrinsic and they're outside. And then, of course, factor number 13, which is fibrin stabilizing factor. And then we talked about protein C and S, where warfarin prevents their synthesis, therefore no clot formation. And lastly, plasminogen is a component of the coagulation cascade, which is responsible for breakdown of clot. So this plasminogen converting to plasmin, it hates the clot. It will break it down. So to prevent that breakdown, we have thrombolytic enzymes and aminocarboic acids. They will affect this section here. Aminocarboic acid is a fibrinolytic inhibitor. Okay? That contact factor is basically 12. 12A will go from 11A to 9A to 10A. In the extrinsic pathway, we have number 7A that turns into 10A. Once 10A is achieved, factor number 2 turns into 2A. 2A is basically prothrombin turning into thrombin. And of course, thrombin converts fibrinogen to fibrin clot. And we have ready fibrin going towards platelets and making a plug. Fair enough? Perfectly nice, I guess. Perfect. Coagulation, cascade, clotting factors. This is basically a treatment modality. Okay? For example, I'll give you an example here. Whenever there is a hemophilia A, it is due to the deficiency of factor number 8. About 30 to 50% of hemostasis occurs, so lots of bleeding, right? Therefore, there is a 100% chance for major bleeding or trauma. The half-life for the infuser factor, so basically when we treat this hemophilia with introducing factor 8 into the system, it takes up to 12 hours for it to reach its peak level. Half-life is 12 hours. So what are they? They are recombinant factor VIII products. There's plasma-derived high-purity concentrates, and so on and forth. Basically, all treatments that treat factor VIII. Same goes for factor IX, which is hemophilia B. Hemophilia C is a fun fact. It is factor number 11. So A, B, C. Okay, 8, 9, 11. And then, of course, 12 we talked about earlier was known as Hageman. And Warfarin factor is an actual factor that creates a disease with 30% bleeding rate. And we must be able to deliver factor VIII concentrates with 1 milligram factor instilled. Perfect, and so on and forth, of course. We get the point. Now, fibrinolysis. Fibrinolysis is the job of plasminogen to plasmin. Now, do we remember, you guys, from our memory, what plasminogen is converted to plasmin with the use of what? Do we remember? It is TPA, plasminogen activator from the tissues. So TPA, tissue plasminogen activator does. Now, much like the coagulation cascade, inactivated follows activated, then execution of the process. Fair enough? So plasminogen exists in the blood and patrols the blood. Just walks around, looks for anything that it needs to cut, like a blood clot it needs to cut, it just looks out for it. Injury leads to the release of plasminogen activator factor. So as soon as there's an injury, of course it needs to clot, but it also knows that I'm going to need to go ahead and stop the clot. So the body releases TPA. The plasmin is now activated and is now formed. It begins to remodel the thrombus, the clot, using what is known as a proteolytic digestion, and that is process. That breakdown occurs in the fibrin network that is sitting on that collagen bed frame with platelets and other fibrin strands. This is the plug, and it starts breaking it. Physiologically, the coagulation and fibrinolysis process must balance. However, in a pathologic condition, it leads to fatal conditions. As soon as this balance is broken between coagulation and fibrinolysis, there's a disease called disseminated intravascular coagulation, and it's called DIC. The stimulation of fibrinolytic system. So what stimulates the fibrinolytic system? What stimulates the breakdown of a clot? We talked about TPA, but there's drugs out there, urokinase and streptokinase. Well, why do we need this? Well, whenever there is a fibrin clot, that is causing occlusion of blood vessels, which then can lead to a stroke. Remember that? Well, you need urokinase and streptokinase to break this occlusion down and prevent any stroke from happening. This is the treatment of blood clotting. Okay, we'll talk about these drugs in the pharmacology section of it in the future slides. Inhibition of fibrinolytic system, which is known as antifibrinolytic. That's the system. Well, aminocaproic acid, tranexamic acid, protamine sulfate, and vitamin K. These would prevent the breakdown of the clot, right? So first of all, we have bleeding, then we have clot, then we have breakdown of clot, and then we have prevention of breakdown of clot. How confusing? Well, not so much. We'll try and make it as easy as possible for you guys, okay? Okay, so moving on, in the important notes section here, we notice that there's anticoagulants and antiplatelets that don't affect the fibrinolytic activity, right? None of these or these are actual antiplatelets or anticoagulants. They're not. They're separate entity. They're known as fibrinolytic and antifibrinolytic. That's all it means. They have association with coagulation factor activities. and platelet behavior, respectively. Anticoagulants have anticoagulant factors. Antiplatelets have platelet behavior changes, but not fibrinolytic. So this section is solo. Okay, so, well, we figured that fibrinolysis is its own process. Lysis means breakdown of the fibrin. For that, we need the plasminogen to convert into plasmin, and therefore we usually ask for the tissue plasminogen activator. Great, but pharmacologically, we have streptokinase and urokinase to help us. It increases plasminogen activity conversion to plasmin, and then plasmin will allow fibrin to make fibrin clot debris. It will break it down into small degradation products. These are thrombolytic. Therefore, fibrinolysis is thrombolysis. Okay, so remember this: plasminogen activation by various stimuli, of course, that make a blood proactivator to blood activator. We looked at that. Remember the factors with letter A. When that happens, along with TPA and urokinase and streptokinase, they adhere to the process of conversion of plasminogen to plasmin. Okay? Now, plasmin does two things. It increases fibrinogen to fibrinogen degradation products, or it actually physically breaks down the fibrin clot into fibrin degradation products. So both inactivated and the activated component of clotting is broken down into debris. So thrombin, useless. The fibrin stabilizing, useless. That's how strong plasminogen is. Now imagine adding streptokinase and urokinase. So essentially, the inhibition using aminocarboic acid, tranexamic acid, and so on, they act as anti-fibrinolytic agents. They prevent plasminogen conversion to plasmin, and therefore degradation products are no longer there. Thrombin wins, factor 13 wins, and fibrinogen gets converted to fibrin clot, and we are happy with the clot. Okay. Let's talk a little bit about streptokinase and urokinase. The mechanism of action of these drugs that are fibrinolytic, it's thrombolytic agents. They convert plasminogen to plasmin, which dissolves the fibrin clot. Clot dissolution and reperfusion of blood occurs with treating early clots only. So if there's a clot that breaks, there are chances of microclots forming. And once they're formed as soon as they do, we must use an adjunct because aspirin and heparin are anticoagulants. Therefore, a big clot that is broken by these drugs turns into smaller clots, and they will want to come together by coagulation. And therefore, we want to prevent that as well. And therefore, antiplatelet or anticoagulants will work to prevent that clot. We talked about the therapeutic use, it being stroke, treatment of stroke due to clots, treating occlusions in restoring catheter or shunt function in a heart surgery. Earlier, it used to be used in myocardial infarction, deep vein thrombosis, pulmonary embolism, but it's no longer used. Okay. Adverse effects, hemorrhage. Of course, we're bleeding. What if there's excessive bleeding? Since these drugs are dissolved, all clots and plugs, there's hemorrhages. Gastric ulcers may hemorrhage out, right? For example, those can hemorrhage out. They're contraindicated in pregnancy and in patients with healing wounds, such as head trauma, metastatic cancer, intracranial bleeding, stroke, which is cerebrovascular accident, CVA due to bleeding. So what does that do for us? It lets us know that streptokinase and urokinase can be used in a stroke due to clots, not a stroke due to bleeding. Remember that point. Okay. Streptokinase is made from beta-hemolytic streptococci. It's bacterial in nature. It promotes and activates plasminogen to plasmids, okay? It degrades and inhibits fibrinogen, factor 5, and factor 7, all of them. And therefore no more clot. Clot is no longer allowed. Urokinase is made from human kidney cells. It promotes, same thing, plasminogen to plasmin. And it's the only drug approved in the market for pulmonary embolism lysis. So in this untreated patient, basically this patient that has a thrombus and hemostatic plug naturally formed, we can see it's a really big thrombus and there's less space for blood to flow. However, there is a plug available. This is healthy. This is something we want. This is something we don't want. Now, as soon as we take plasminogen activator treatment, so if essence we got the TPA or we got the streptokinase, all of these treatments, then the plasminogen converts to plasmin, the thrombus, the fibrin clot is broken down, and we have more space for blood. Perfect. But hemostatic plug is also broken down, and now we have bleeding. That's the problem with fibrinolytics. So streptokinase plasminogen creates a streptokinase plasminogen complex, and we're back to square one, which is plasminogen to plasmin, fibrin to debris. Fibrinogen to fibrin positively feeds fibrin degradation products. Clot is dissolved. When fibrinogen, the inactivated molecule, positively feeds into debris, then it's known as lytic state. Just a little bit of a side information to remember. Okay, antiplatelets and platelet aggregation inhibitors. We spent some time learning about platelet aggregation. But what about antiplatelets? Well, the main functions are decreases the formation of the clot. Perfect. That is rich in platelets only. So it blocks what is known as a cyclooxygenase 1, also known as COX-1. So now we introduce COX-1. Here I'd like to mention that please visit our NSAIDs lecture. It has a lot more depth into COX, but we'll still go into this as well. It blocks COX, and COX is supposed to create the clot. Okay? When COX is supposed to create the clot and antiplatelets break it, the clot doesn't occur in the first place. We're not breaking down the clot. We are preventing the clot. So it decreases the chemical signals that invite platelets, therefore it blocks the ADP, adenosine diphosphate. Remember the signals. It decreases the molecular bridge that is activating the platelets with one another. That is the GPs, glycoproteins. It blocks everything, antiplatelets. So what is COX-1? Well, COX-1 is an enzyme, okay? It converts something known as arachidonic acid into prostaglandin H2. Remember this, arachidonic acid into prostaglandin H2. Prostaglandin H2 converts into thromboxane A2. Remember you guys, the big gun back is now thromboxane A2. This converts into thromboxane A2. Prostaglandin H2 converts into thromboxane A2. Thromboxane A2 directly acts as a platelet aggregation process, a thrombosis causing chemical. So remember, along with serotonin, along with ADP, along with thrombin, we had thromboxane A2. That created a platelet aggregation. Some antiplatelet drugs like aspirin, they block COX. Okay, right here. They block COX. No H2, no thromboxane, no platelet, nothing. All of that gone. This favors increased levels of prostacyclin, and therefore clot is prevented. Remember, when prostacyclin is activated, there's less platelet. So this favors increase in prostacyclin, and therefore it prevents clots. Common antiplatelets that we talk of are aspirin, clopidogrel, ticlopidin, and of course the efiximab. So this is the diagrammatic format. This is the activation and aggregation of platelet. Remember, platelet activation, platelet activation, platelet aggregation. Platelet aggregation, receptors form a fibrinogen bridge with one another, and now we have a plug. Great. Activated glycoprotein receptors, they're blocked by absciximab. Absciximab blocks it, therefore fibrinogen is like, oh, where do I go? I don't have a place to go. You think, okay, I'll go back home. And as soon as it goes back home, we have antiplatelet, because platelets cannot stay with one another. And the gap is created, therefore the clot is now prevented. Okay? This is ticlopidin, clopidogrel, and ticagrelor. Basically, there's ADP, right? So, a damaged endothelial cell that has collagen bed has platelets. Platelets send ADP. ADP goes to our next platelet and says, hey, increase your calcium. I have to go out and join the party. ADP, that's the message that it sends out. Calcium then goes to glycoprotein, and glycoprotein says, all right, where's the rest of the party? And it tries to chase the party. But ADP is blocked. ADP is blocked by ticlopidin, clopidogrel, and other antiplatelet drugs. Okay. Well, what does aspirin do? We talked about other drugs in antiplatelet. Well, here's aspirin, you guys. In antiplatelet activity, we have a tissue injury. Tissue injury occurs at membranes. The phospholipid, remember back in the day we had the phospholipid bilayers that we used to talk about? Those will release an acid into the membrane known as arachidonic acid. Arachidonic acid uses COX-1, cyclooxygenase 1, as an enzyme that creates prostaglandin H2. H2 is head, just head. Remember head, the biggest prostaglandin. It has 3 children. It has prostaglandin E2, prostacyclin I2, and thromboxane A2. Okay? This down here, I'm not sure if you can see in the screen recording, but it says platelet aggregation. Okay? Platelet aggregation. So essentially speaking, the thromboxane A2 is supposed to aggregate platelets. Prostacyclin I2 prevents platelets. And prostaglandin E2 is actually just for pain, inflammation, and fever. These things. That's what E2 is for, so irrelevant in this lecture. But in the lecture of NSAIDs, we talk about all of this. So, why this story? Well, think of it this way. What if I tell you I'm going to block this by aspirin? Well, then there's no head, no children, thromboxane A2, but because some activity still exists, prostacyclin gets activated, and therefore it increases prostacyclin activity. Fair enough? Aspirin also acts as pain relief, remember? Do you remember it acts as an anti-inflammatory, an antipyretic, and that's where NSAIDs come into play. How cool is that? We're linking lectures now. So, all in all, essentially, membrane phospholipid, arachidonic acid. Arachidonic acid, prostaglandin H2, prostaglandin H2, thromboxane A2. Thromboxane A2, platelets. We block it by aspirin. Simple. Perfect. Moving on. Aspirin. Now we're stepping into drugs, the pharmacology section. Remember to see the NSAIDs lecture, you guys. The mechanism of action for aspirin is that injury stimulates the membrane phospholipid to instigate arachidonic acid to pass, convert into prostaglandin H2 by an enzyme called COX-1. Ultimately, it ends in thromboxane A2, which is responsible for platelet aggregation. However, aspirin inhibits COX-1 irreversibly, gone, at the beginning of the process, and that's why it's antiplatelet. Indirectly promotes the prostacyclin action, and it's of course subjective to the matter of doses as well. So, 81 milligrams, for example, 262 milligrams, that's okay as antiplatelet. 1000 milligrams, that's just a painkiller. What that does, 1000 milligram, is it blocks this. 81 milligram blocks here. So essentially it's dose dependent, but we'll take a look at that ahead. A therapeutic prophylactic treatment of transient cerebral ischemia, prevention of myocardial infarction. Remember, we initially said arterial blockage is platelets. Venous blockage is coagulants. Myocardial is a coronary artery disease. Therefore, we need antiplatelets. Therefore, this is aspirin. Okay. 75 milligrams daily, complete inactivation of platelets. So low dose, right? Recommended dose is 50 to 325 milligrams daily. I say 81 to 162 is good as per research. Higher dose of aspirin has analgesic and anti-inflammatory actions as well. Adverse effects, as such, salicylism is a huge topic on its own, but essentially that's in the NSAID lecture. So please go and check that out. Higher doses can cause toxicity known as salicylism. Higher doses can block prostacyclin as well. Now imagine if it blocked prostacyclin as well. It blocked platelet aggregation, platelet prevention, pain, inflammation, everything. It just shuts the system down. Therefore, there then will be increased incidence of hemorrhage, increase of bleeding time, complications in stroke and GI bleeds. And once you take it with ibuprofen, antiplatelet actions are blocked as ibuprofen occupies the same receptors first. Then immediate release aspirin should be used, taken 8 hours after ibuprofen. So don't mix ibuprofen with aspirin. That's a bad combination because the dose throws off. Okay. Moving on to clopidogrel, ticlopidin, ticagrelor. These are other antiplatelets. Remember, ADP blockers as well as GP2B3A blockers. They both block them and inhibit their actions. Therefore, platelets cannot bind to each other. And of course, fibrinogen cannot find its place in between the two GP receptors. Only ticagrelor is reversible. Others are irreversible. Okay. Clopidogrel takes 3 to 5 days for peak effect. Ticlopidin 3 to 4 days, very similar. Ticagrelor 1 to 3 hours. So ticagrelor being reversible, it is a reversible fast-acting drug. Therapeutic uses: clopidogrel, prevention of atherosclerotic events such as MI and stroke patients, peripheral arterial disease, remember that, arterial, and acute unstable angina, which is essentially MI. Ticlopidin, prevention of TIAs, which is transient ischemic attacks that has to do with the brain not receiving enough blood and oxygen. Ticagrelor, prevention of arterial thromboembolism, arterial thromboembolism in unstable angina and MI. So a lot of MI and heart attacks. Okay. Adverse effects, there's no antidotes for prolonged bleeding caused by these drugs. Well, as of now, they're still researching on it, but nothing yet. Clopidogrel, the lowest hemorrhagic events of these. So clopidogrel is safe. It's a very safe, lowest hemorrhage. Ticlopidin causes agranulocytosis. Now that's pretty bad. There's thrombotic, thrombocytopenic purpura, and aplastic anemia. So basically, ticlopidin, unsafe. Ticagrelor diminishes effect if used with aspirin, just like ibuprofen, aspirin over 100 milligrams. So in all, this slide, clopidogrel wins the race. Fair enough? Awesome. Efzimumab and eptifibatide and tirofiban. These are those drugs that specifically act on the glycoprotein receptor inhibition, where the binding of the fibrinogen, factor number 1, takes place, and von Willebrand factor, which is also associated with bleeding and its diseases as well. Remember von Willebrand disease? Well, ultimately fibrinogen, the inactivated component, converts into fibrin and is activated. However, this is prevented. Hence, clot is prevented. So it's the last stage. The conversion of fibrinogen to fibrin is also prevented by epsiximab and the rest of the drugs. IV only can be given adjunctively to prevent cardiac ischemia and treatment of a very specific intervention, which is percutaneous cardiac intervention. This is actually a heart treatment. Okay. Unstable angina patients not responding to any other treatment can rely on this particular drug right here. Okay. Adverse effects, excessively bleeding, that's basic, and especially used with anticoagulants together, not a good idea. Moving on to anticoagulants. Okay, anticoagulants classification is based on the mode of administration. There's parenteral and there's oral. Parenteral just means injection, where there's indirect thrombin inhibitors, which is heparin, low molecular weight heparin, and other drugs. Direct thrombin, drugs that we won't talk about. However, this section right here, very, very important. So let me get rid of the pen right here. Oral anticoagulants, coumarin derivatives. These are warfarins. That's all we need to know. Warfarins. Direct factor 10A inhibitor. Do you guys remember 10A from the earlier diagrams back here? Let's take a look here. 10A, 10A. This is a good diagram right here. I'm going to clear. All right, so 10A. 10A creates thrombin. Remember that? And thrombin creates clot. Right? So this drug that we're just talking about blocks number 10A itself. Rivaroxaban, very important. And of course, oral direct thrombin inhibitor, dabigatran. So important drugs, heparin, warfarin, rivaroxaban, and dabigatran. Okay, 4 drugs. Let's talk about heparin. Mechanism of action, injectable rapid-acting anticoagulant. So essentially any venous diseases, remember? Okay, so keep that in mind. Anticoagulant, venous disease. That interferes with the action of coagulation factors, forming a thrombus. Fair enough. Naturally occurring macromolecule mixed with histamine and mast cells. They're extracted from pig intestine mucosa to be created. So that's heparin. Heparin is from pigs. Actively binds, this is the role now, it actively binds to antithrombin number 3. So what is thrombin? Thrombin is number 2. That creates clot. Antithrombin, anti number 2, anti-clot. It binds to it, causing heparin antithrombin complex. What does this do? This prevents the activation of coagulation factors. Antithrombin 3 normally slowly inhibits factor 2A thrombin. Okay, essentially it does, like antithrombin right here, it slowly inhibits factor number 2, which is thrombin. Okay, and factor number 10A very, very slowly. But with heparin, it is catalyzed, it's sped up. So as soon as heparin is added to this antithrombin, it's fast conversion. And number 2 and number 10 blocked faster using this heparin antithrombin complex. So heparin disassociates after it's been blocked, and then it goes back to be reutilized. How convenient is heparin? This inhibition of thrombin is fast-forwarded 1,000 times, you guys, times by 1,000. And it's reusable. Now, in this case, we can see two types of heparin. Heparin, low molecular weight heparin. Okay, let's take a look at what they do. Heparin, in antithrombin, it attaches itself like a fast-forward car. As soon as that happens, factor 10A and factor 2A, they both get attached to antithrombin and heparin complex individually. Unfractioned. Heparin accelerates the interaction and clot cannot happen. Great. Low molecular weight heparin attaches to just factor 10A and not thrombin. So it selectively accelerates the interaction with antithrombin and factor 10A. So if anyone asks, heparin is 2 and 10. Low molecular weight heparin is just 10. Okay? Heparin therapeutic uses. Prevention of fibrin clots, used in the treatment of acute venous thromboembolism, deep vein thrombosis, pulmonary vein embolism, prophylaxis of postoperative venous thrombosis in surgeries in patients and MI patients as well, mild effect. Drug of choice, anticoagulant therapy in pregnant women, something to note down because it does not cross the placenta. Warfarin crosses the placenta. So if the patient is pregnant and you have to give anticoagulant therapy, heparin is your go-to, not warfarin. Adverse effects, bleeding beyond control. But there's a reversal agent known as protamine sulfate. Fever and chills and urticaria, anaphylactic shocks or other adverse effects. Heparin-induced thrombocytopenia, HIT, which is blood with abnormally low numbers of platelets leading to immune-mediated embolic conditions. Contraindicated in HIT, instead, please use argatroban. If a patient is diagnosed with heparin-induced thrombocytopenia and you want to do anticoagulant therapy, please use argatroban. Then we have recent surgery, alcoholism, bleeding disorders, inappropriate to use heparin. They're already prone to bleeding. And heparin can cause hypersensitivity reactions. So essentially what to remember: excessive bleeding, hypersensitivity reaction, and thrombocytopenia, the HIT, heparin-induced thrombocytopenia, okay? Dabigatran. Mechanism, full name is dabigatran etexylate. It's a prodrug, basically, of active dabigatran. Direct oral thrombin inhibitor. Thrombin is factor number 2, blocks it directly. Reversal agent, idarucizumab, is dabigatran's reversal. Therapeutic uses, prevention of stroke, systemic circulation of embolism, thromboprophylaxis and orthopedic surgery, so that clots don't occur after the surgery is finished, and does not need INR. What is INR? International Normalized Ratio. Unlike warfarin. Now, one more drawback of warfarin, guys? Now, fewer drug interactions are compared to warfarin. So dabigatran is safer. Warfarin, not so much. Adverse effects. We have excessive bleeding. Use with caution in renal impairment because it excretes through renal, and age above 75 because liver functions drop. Dyspepsia, abdominal pain, esophagitis, and GI bleed, as well as abrupt stoppage of doses can cause thrombotic events. This thrombosis takes place very fast afterwards. And it's contraindicated whenever there's a mechanical heart valve, prosthetic heart valve replacement, which is mechanical. Apixaban, rivaroxaban, we talked about that drug. Oral inhibitor of factor number 10. Prevents the conversion of prothrombin to thrombin. Remember, factor 10 does that. When there's no thrombin, no clot. And andexanate alpha is the reversal agent for rivaroxaban and apixaban. These are fairly common questions in the exam, so keep an eye out for them. In therapeutic uses, rivaroxaban is used in the treatment and prevention of course, deep vein thrombosis and pulmonary vein embolism. Apixaban for stroke prevention in arterial fibrillation of non-valvular kind. So you won't be asked that a lot, just remember stroke patients. Adverse effects, of course, bleeding. It eliminates renally, so taking care of that, as it declines the renal function over time. Abrupt discontinuation of the drug should be avoided because it will cause thrombotic events. Finally, warfarin. I don't know if it's the villain of the hour or the hero of the hour. Warfarin is the coumarin class known as comudin, is another name for warfarin. It is antagonized the cofactor vitamin K. So vitamin K creates clots. Remember that. Warfarin blocks it, no more clots. Initially, it is used as rodenticide. It killed mice, rodents. Now it is an oral anticoagulant. How exciting. INR is the best test mandate for monitoring and correcting the effects of warfarin. INR is basically the international normalized ratio, where the goal of the ratio is 2 to 3 units, 2.5 to 3.5 units, depending on some procedures. What that really means, what it signifies, is that INR 1, the ratio of 1, essentially 0.8 to 1.1, is equal to a normal vessel that, bleeding time is normal, clotting time is normal, things like that. Higher the INR, higher the risk of bleeding. So in a patient whose INR is 5 and is taking warfarin and needs to go to surgery, we can't do the surgery. We need to correct the dose of the warfarin to bring down the INR to the goal units 2 to 3, 2.5 to 3.5, and then we could do the surgery. That's basic concept. Warfarin also has a narrow therapeutic index, which makes INR even more important to monitor. Mechanism of action. Factor number 10972 need vitamin K to have synthesis. So basically coagulation factors need vitamin K as food so that they can be synthesized in the liver. Vitamin K is a reproducible molecule from the process of vitamin K epoxide reductase. Basically, vitamin K epoxide reductase is an enzyme that regenerates vitamin K. Warfarin inhibits this enzyme. Vitamin K epoxide reductase, warfarin blocks it. No more vitamin K, no more factors, and no more clotting. Unlike heparin, warfarin takes 72 to 96 hours to reach maximum efficacy. Reversal agent for vitamin K? Naturally, vitamin K. You want to kill vitamin K, just administer more, which takes another 24 hours to act at maximum capacity. So, remember that warfarin affects 1972. There was a war in 1972 where vitamin K was the resource people fought for. And in that, only way to resolve and fix the war, reverse the war, is to provide the people with vitamin K supplements. This is a story, not a true story. I remember I said I'll make jokes. So, warfarin, 1972. Factor number 10972 is blocked by warfarin by indirect, right? Because vitamin K is needed to produce these in the liver. Warfarin blocks vitamin K directly, therefore indirectly blocking coagulant factors. Okay. Pharmacokinetics of warfarin. Rapidly absorbed orally, 100% bioavailability. You can check out our general pharmac lectures in the back for more details on bioavailability and plasma protein binding. Highly bound to plasma albumins. preventing its diffusion into cerebral sinus fluid, urine, and breast milk. Other drugs such as sulfonamide, sulfonylureas, and other NSAIDs, they have a higher affinity for albumin as well, which means that in competition for albumin, warfarin will lose. And there will be in the blood causing transient and longer action, more than it needs to be. So drug-drug interaction. This can be found in our lecture of drug-drug interaction as well. It does cross placental readily, therefore it's dangerous in pregnant women. It is metabolized by CYP450, which is another topic in general dental pharmacology as well as drug-drug interaction. Please do check it out. It is excreted through urine and extensive drug interactions take place. Extensive. Adverse effects, hemorrhage, purple toe syndrome, where there's a rare purple painful toe caused by cholesterol emboli from plaques, atherosclerotic plaques. Teratogenic, hence contraindicated in pregnancy. Instead, we should use light molecular weight heparin. Skin lesions and necrosis are also rare complications of warfarin. So remember the whole vitamin K war we were talking about? Well, here it is. Normally, a decarboxyprothrombin turns into thrombin by the use of an enzyme that is gamma-glutamyl carboxylase. The same enzyme converts vitamin K from one form to another form. Therefore, this right here, this process is what makes thrombin, okay? Ultimately, factor number 2. And of course, other molecules such as the 1972. Now, vitamin K has its own cycle down here, where vitamin K epoxide will use vitamin K epoxide reductase to come back to its natural vitamin K hydroquinone form. However, warfarin blocks this scenario right here. And therefore, vitamin K can never turn into activated form. It will always stay deactivated. And therefore, these up factors right here will never be made. That's the story. Okay? Essentially, vitamin K reduced, epoxide, which is oxidized vitamin K, turn into reduced. All of that occurs right here as gamma carboxyl glutamyl reductase is taking place. This is responsible for formation of prothrombin. Prothrombin turns into 1972. So, warfarin blocks this area right here. Okay. One more thing here, very important, that warfarin has a two-way double-edged sword. Warfarin, in acute alcohol intoxication, amiodarone, fluconazole, metronidazole, sulfamethoxazole, trimethoprim, all of these drugs, it inhibits the metabolism of warfarin because of CYP450. They all are metabolized by that enzyme in the liver. Warfarin's metabolism is inhibited, therefore warfarin is still active. Therefore, potentiation of anticoagulation activity, therefore inhibition of platelet aggregation, and that's what aspirin does as well. Okay, so warfarin with these drugs become even more active. However, in chronic alcohol, in indigestion, barbiturates, dicloxacillin, and rifampin, these are also in CYP450 family's metabolism, but they stimulate, they increase the metabolism of warfarin, and therefore they create faster anticoagulation action, Okay, so it doesn't last long. That's all it means. It doesn't last long. Here is warfarin compared to heparin. In chemistry, of course, they're mucopolysaccharides and coumarin derivatives. Heparin is from pig's intestines. Warfarin is synthetic. Heparin is IV or subcutaneous. Warfarin is an oral drug. Heparin immediate, warfarin delayed up to 1 to 3 days. Remember, 72 to 96 hours. Duration of action, 4 to 6 hours for heparin and 3 to 6 days. as well as activity in vitro, in vivo, and this can only be done inside a body itself. A mechanism, heparin blocks the action of factor 10 and thrombin, so 2 and 10. Inhibits the synthesis of clotting factors, 1972. Antagonist, protamine sulfate. Antagonist, vitamin K. And then, of course, in terms of lab controls, for heparin, we want APTT. In warfarin, we need PT, or more essential, INR. Drug interactions, heparin has few, non-significant, but warfarin, oh my goodness, it has a lot. Please check out our drug interaction lecture. Perfect. And then, of course, lastly, our last stage is drug used to stop bleeding at the very last stage. You know, after fibrinolytics take place, this is all fibrinolytics, right? That fibrin is lysed into debris. We looked at this diagram already. But antifibrinolytics, basically things such as aminocarboic acid, these guys. Essentially, that's what's antifibrinolytic. And where is antifibrinolytic used? Antifibrinolytic is used in hemophilia A, B, C, von Willebrand disease, factor 13 deficiency, then the factor 1 and 2 deficient, like all the factor deficiencies, we can use antifibrinolytic as an adjunct as well. Drug used to stop bleeding, antifibrinolytics, so such as bleeding disorders, hemophilia, fibrinolytic states after surgery, where the bleeding just won't stop. That's where we use these drugs. Same goes for the overuse of anticoagulants, right? So, for example, warfarin overuse is reversed by vitamin K. In order to control bleeding, vitamin K and synthetic antagonists such as antifibrinolytics are effective. Blood transfusion and donated coagulation factors. So if you look at this chart, these are all coagulation factors. So recombinant factor product, right? These are basically used. These FFPs are also factor products. These are donated blood, basically. Drugs that are used to treat bleeding. They include, of course, vitamin K and protamine sulfate. This reverses warfarin. This reverses heparin. Aminocarboic acid and tranexamic acid is the inhibition of plasminogen to plasmin. Simple. All right. Aminocarboic acid, synthetic drug that controls bleeding by fibrinolytic states blockage. Orally ingested and excreted in urine, they inhibit plasminogen activation into plasmin. Tranexamic acid is 10 times more potent than aminocarboic acid. Adverse effects is intravascular thrombosis. This is clot. Of course, it's the opposite effect, right? Protamine sulfate reverses heparin. Adverse effects are dyspnea, flushing, bradycardia, hypotension. All of that can occur due to rapid injection. And the king, vitamin K. It antagonizes warfarin. Needs 24 hours to reduce the INR if needed for a patient on warfarin treatment. Perfect. Beautifully. Thank you for staying, you guys. You guys are doing great. Hopefully this lecture makes a lot of sense and we're learning lots of things. And of course, these are just summaries of the drugs that we just talked about. Please do come here and take a look at them, pause them, write them down in your notes. Hemostasis in dentistry, a very short note for how to control bleeding in dentistry. Normal hemostasis occurs following a dental procedure like extraction by contraction of the injured vessel, adhesion and aggregation of platelets for a plug, formation of a blood clot, and finally, in due course, dissolution of clot by fibrinolysis. We learned all that in the past 40 slides. However, post-extraction bleeding can be stopped by 20 to 30 minutes of pressurized gauze pack and other local hemostatics. They are known as styptics. Okay, so remember that terminology. Styptics are used to stop bleeding, and they are absorbable, such as fibrin and thrombin packs, gelatin foam, oxidized cellulose. These are strips that can be inserted into sockets. And we could also use vasoconstrictors, so that's 1% epinephrine adrenaline solution basically. And astringents, also something that stops blood, such as tannic acids, metallic salts like alum, ferric chloride for gum bleeding. Remember alum? Most guys used to use it when they used to shave. It's potassium bar. Alum. When they shave, there's cuts on their faces. That's when they use alum bar. It looks like a transparent soap bar. That's what it looks like. Okay. Hemophilia patients with minor dental procedures like scaling. In that, we must use IV infusion antihemophilic factors with fibrinogen. Tranexamic acid can be used as an adjunct as it is 10 times more potent than aminocarboic acid. And then, of course, desmopressin IV can help with von Willebrand disease and hemophiliacs as well. And this is the summary of all the drugs that we just discussed from our references. And these are our references for today. Links are in the description box for you guys to purchase as well. And of course, we have started our classes where we teach one-on-one. The link is in the description box below. Please do check it out. We'd love to have you and clear your doubts. Thank you very much for staying behind such a long lecture. Have a great day.